Our next presentation is by Louis Yu, entitled Aortic Great Vessel Injury in the Pan-Scan Era.
Hello, my name is Louis Yu. I'm a fourth-year emergency medicine resident at UCSF, and today I'll be presenting aortic injury in the era of Pan-Scan. This work was funded through the CDC, through an R01, and through the University of California Health Quality and Innovation, and I have no other financial information to disclose. All right, so sorry, one second. Is there any way to get my notes on here? No? All right, great. So basically, we've had increased use of the head-to-pelvis CT scan over the past 20 or so years. And this is a big change in our practice in emergency medicine. The classic teaching of, about aortic injury are also from over 20 years ago. And it is time that we had an update. Thankfully, we have the Nexus chest CT studies, which provide the largest, most modern, prospectively derived database of adult blunt trauma patients to accomplish this. So in terms of our objectives, we sought to update teachings regarding aortic great vessel injury, in particular the incidence in patients who received imaging in the emergency department. We also wanted to look at the proportion of patients with isolated aortic great vessel injury, meaning without any other thoracic trauma. Third, we looked at the clinical implications, including hospital length of stay, mortality, and rate of surgical interventions. And then finally, we also wanted to evaluate traditional risk stratification methods as compared to newer criteria, such as the Nexus chest CT decision instrument, at identifying patients at high risk for aortic or great vessel injury. This was a pre-planned secondary analysis using data from the 4 Nexus chest studies. It was multi-center, took place at 10 level 1 trauma centers, and the inclusion criteria were age greater than 14 years. You must have presented to the emergency department within 6 hours of blunt trauma, and you must have received chest imaging during your time in the emergency department. This was a consecutively enrolled study during daylight hours, 7 a.m. to 7 p.m., and patients received a callback at 2 weeks. A subset of patients received a callback to assess for injuries or need for repeat hospitalizations. Protocols were identical in all 4 studies. So, what are classic risk stratification markers? Rapid deceleration mechanism and widened mediastinum are the most frequently referenced. Now, these criteria are frequently used to screen for potential aortic injury, but given the devastating nature of aortic injury, they're not frequently used to rule out pathology. Now, for those of you not familiar with the Nexus chest CT decision instrument, this is a newer criteria developed to identify an extremely low-risk group of blunt trauma patients in which a chest CT can be foregone. When used appropriately as a one-way directive tool, the Nexus chest CT decision instrument has been shown to decrease CT scanning of the chest by 25 to 37% in selected patient populations. Now, this brings me to our primary outcomes, which include 1, incidence of aortic great vessel injury, meaning the incidence of aortic injury in patients who survived to imaging in the emergency department. 2, the proportion of patients with isolated aortic great vessel injury, meaning without any other injury seen on chest CT. 3, we looked at the sensitivity of widened mediastinum and rapid deceleration mechanism as defined as widened mediastinum on a chest x-ray read by an attending radiologist, and rapid deceleration mechanism defined as a motor vehicle collision greater than 40 miles an hour or a fall greater than 20 feet. And then we looked at the sensitivity of the Nexus chest CT decision instrument criteria alone and together. Secondary outcomes included clinical outcomes, such as inpatient mortality, surgical intervention rate, prevalence of associated injuries, and hospital length of stay. The Nexus chest studies, there were 4 of them from 2009 to 2014. I have them listed here. Not every patient received a chest CT because it was often not clinically indicated. In total, 24,010 patients were enrolled, and 10,188, 3 of which received a chest CT, which is about 42%. Of those patients, 42 had an aortic great vessel injury, making the incidence of aortic or great vessel injury 0.2%. In regards to patient characteristics, the majority of patients were male in both cohorts, meaning those with aortic injury and those without. GCS was similar. And the injury severity score was higher in the aortic great vessel injury patients at 29 as compared to 5. In regards to mechanisms of injury, all patients in the aortic great vessel injury cohort did have a high energy or traditional high energy mechanism of injury. The 2 patients here listed in the other or unknown category were in a plane crash and crushed by a vehicle, respectively. Over 22%, or around 22% of patients enrolled in the Nexus chest studies had a low energy mechanism, such as a fall from standing or an assault. And of those, 0 patients had an aortic or great vessel injury. Not surprisingly, 100% of patients with aortic injury were admitted. Mortality, though, was surprisingly low at 9.5%, or in other words, 4 patients. Of those 4 patients, 0 died from their aortic injury, and all 4 died from complications of traumatic brain injury. The rate of surgical intervention was 57%, and the hospital length of stay was higher in our aortic injury cohort as compared to all comers. Associated injuries. So, most patients, or 88%, did have an associated injury, although a relatively high number of patients did have a isolated aortic injury. And again, we're talking just in the thorax. The most common associated injury was rib fracture, followed by pneumothorax, pulmonary contusion, sternal fracture. And many patients, a little over half, had multiple thoracic injuries. Here, we look at sensitivity. And sensitivity is driven by the number of false negatives. Traditional risk stratification methods or criteria, such as wide mediastinum and rapid deceleration mechanism, perform poorly, with 28 and 14 false negatives, respectively. They each had relatively low sensitivities for what we're trying to do here. The individual criteria for the Nexus chest CT decision instrument performed also poorly individually, but when taken in conjunction, the Nexus chest CT decision instrument missed no aortic injuries, detected all aortic injuries, and had a high sensitivity, the low end of the confidence interval, around 92%. There were several limitations to this study. One, not every patient had the gold standard chest CT, which could introduce some detection bias. Due to our protocols, we think this is unlikely. Patients that died before imaging were not captured, meaning patients that died in the field or died immediately upon arrival at the emergency department were not included. So we can't comment on the true incidence or mortality of aortic injury. 3, a small number of patients with aortic injury were enrolled in this study, leading to wider confidence intervals. We come away with 4 conclusions regarding clinical outcome. 1, aortic injury is rare. The incidence is 0.2%. As we are scanning more patients, our yield of chest CT is going down. 2, aortic injury more commonly occurs with other injuries, but a significant number of patients can present with an isolated aortic injury. 3, inpatient mortality is low at 9.5%, and none of the patients with aortic injury died from their complications of the aortic injury. And then 4, no aortic injuries were seen with low energy mechanisms, such as fall or assaults. Fall from standing or assaults. And finally, classic risk screening markers are insufficient to rule out aortic injury. The Nexus chest CT decision instrument, however, detected all aortic great vessel injuries and performed well, albeit in a very selected patient population. Thank you very much. I appreciate your attention, and we'll open it up for questions.
Thank you, Dr. Yu, for your excellent presentation. The abstract is open for questions. I have a question. You had mentioned that the mortality was low. And how do you believe that this impacts our application of these study findings to clinical practice?
From an emergency department perspective?
Correct, yes.
I don't think it actually will change my clinical practice per se, but it is an interesting component of this. So if you look from 2003 to 2007, the mortality did decrease, and I think it more reflects how we're managing these from a surgical perspective. Endovascular repair has become pretty much the only way these are treated. There are very few open repairs these days, and I think that's probably a large part of the low mortality. Given that this was an observational study, hard to comment on sort of other factors that may be affecting mortality.
Okay, great. Thank you very much.
Thank you.